Okay. Does it record your screen though?
I don't know. I'll just have to play with it a little bit,
Right.
but it there was a record button on there.
Because I think the YouTube one is going to record you and not what's on your screen.
Mm.
I think. So, anyways, so I'm going to be recording this. The plan is we're going to upload it to YouTube and make it available to the department as a whole and reuse it over the years. Um, we're going to be covering two different topics: sepsis and then diabetes and DKA. Each one will be about an hour. I'm going to start with sepsis. We'll do the hour, record it, take a break, and then come back for the DKA. I am at the other job, so if I get shuffled away for something, Kelly will take over. We got about 50 slides for the sepsis. Pretty big component of it is going to actually be infectious disease. Reason for that is because infectious disease is all up in our business these days. All sepsis comes from infectious disease. It comes from a bacteria or a virus. It leads to extreme illness. If you don't start with that infectious disease, though, you don't end up with sepsis. You end up with MODS or ARDS or something else that's created from trauma or other inflammatory problems. To get CEs, you do have to do the test and the course evaluation. No, I think I got the test from both of y'all already, so you guys are sorted there. And if you're
Our
watching
answers
this,
if we goof this, right?
yeah, well, I do have to grade them still.
Okay, cool.
So if you're watching this after the February 24th, 2021, and you want to try to get CEs, just send me an email at tkinney@tcesd1.org, and I'll get you the stuff. Keep in mind, if I'm not on with you through a Google Meet or actual lecture, then it's only distributive CEs. I think that's all the disclaimer stuff I need. So you guys should be good for just any kind of CE on this. And then on Friday, we'll play it again, but I'll be on Google Meet with you all to answer questions, so it counts as instructor guided. So introduction: infectious disease, illness caused by any infestation of body by biological organisms, and that can be anything from bacteria, virus, fungus, protozoa, helminths or prions. A lot of these can be life-threatening in and of themselves. A lot of times they lead to SEERS and SAR and sepsis that leads to a more life-threatening problem. We're often the first people to encounter, so somebody might get sick, they're at home by themselves, they start feeling bad. After about a week of feeling bad, they're so sick and blood pressure's so low that they can't get up, so they end up calling us. And we might focus on, as we just discussed about, red herrings sending us in the wrong directions. We might focus on a low blood pressure and not realizing why they're that way. There is a sepsis protocol that we have here at TCSD1. All departments have one now. I'm going to say this a few times, but if their heart rate's up, blood pressure's low, and they have a high temperature or a very low temperature, suspect sepsis. Usually their temperature is going to go up. There are some bacteria, some staph that will cause your temperature to actually drop first. Right, majority of disease-causing organisms are microscopic, meaning you have to see them under the microscope. You can see some protozoas and some amoebas without it, but you still need some kind of lens. You could look through binoculars backwards and actually see some amoeba. We're going to talk a little bit about how to stain and see some of that stuff under a microscope, more out of interest than any paramedic need. If you're doing gram stains in the back of your ambulance, it might be the 1900s. Normal flora. So we have a normal amount of bacteria in our system that is part of our primary metabolism. So they're in our gut, they're in our intestines, and they help us break down nutrients that we normally can't access. That's pretty normal, and one of the big side effects of that normal flora is that it actually inhibits the growth of bad bacteria. So the normal flora is there because it can survive and it can do well and it helps us. There's a symbiotic relationship there. And it also, by being there and taking up the nutrients and taking up the resources, prevents other illnesses from taking hold. And we'll talk a little bit later about how some of the treatments that we get for bacterial infections actually can mess up our normal flora, which can actually lead to fungal infections and other kind of less common infections. So microorganisms, micro being small organism, opportunistic pathogens, they're non-harmful bacteria Um, Normal flora are opportunistic pathogens, are unharmful bacteria that cause disease only under unusual circumstances. So a lot of times we have like part of our normal flora, like we have staph all over our skin. It's not an issue. It's not a big deal. But if say we come down with the flu and now our immune system is taxed fighting the flu, that normal flora might actually take hold and propagate, causing a staph infection, which can lead to more problems. And that's why a lot of times when you do have the flu, the doctors will put you on antibiotics, which is a antibacterial medicine instead of an antiviral, because your body's fighting the virus. So the doctor puts you on something to help you fight that bacteria to prevent secondary infections. And of course, anybody that's immunocompromised, you need to be ultra careful about infection. If they're immune compromised and you're doing IV in the ambulance, take those extra steps to be ultra clean. It's not something we usually do for really sick patients, but in this case, it can actually make a huge difference. We're going to cover a few different microorganisms, bacteria, viruses, fungi, amoebae, protozoa, things. So bacteria, they're microscopic, single-celled organisms, 1 to 2 micrometers. They're prokaryotic, which means their cell wall is different than a eukaryotic. Humans are more eukaryotic, if I'm not mistaken. They produce independently. Okay, so one of the things that differentiates a bacteria from a non-bacteria. I just realized my door's open. I'm teaching my nurse stuff she already knows. So bacteria, they actually metabolize, and that metabolism is strictly focused towards reproduction. There are some byproducts of that reproduction, and oftentimes that byproduct, that waste product, is what makes humans sick. Gram-Stain method of differentiating bacteria. So a guy named, what was his name? Hang on, check out the slides. So you can see here that I use Wikipedia. Can you guys see those? So keep in mind that anytime you're using Wikipedia, you can always verify what you're reading and its validity by going down to the bottom and the references. Usually it's better reading more scientific papers. Wikipedia is peer-reviewed, and that's why they have to reference everything. Anyways, the guy's name is Graham. That's where the Gram-Stain name comes from. Can you guys see the slides again? Yep, all right. So Gram-Stains, it can be gram-positive or gram-negative, and that just differentiates two broad spectrum differences in the bacteria. Usually the gram-negative ones are the ones that cause a bigger problem. Their cell wall is actually thinner, but more robust. So when you stain, you use a violet color, and if it's a gram-positive, that it'll absorb that. After it absorbs it, you rinse it out with alcohol, and if it's a gram-negative, that alcohol will wash out the purple staining, and then you do a counter stain, which is red. So if it's purple, it's gram-positive. If it's red, it's gram-negative. Bacteria come in all different shapes and sizes. Here's a different list of them. They're round, they're rods, or spirals. Each one signifies a different type of bacteria. And you could take a pretty basic microbiology course and get the hang of all that pretty easily. So if you have a heavy infection, like a heavy colonization of bacteria, it can actually cause tissue damage. That's less common. Usually, again, it's the byproduct of that bacterial metabolism that causes us to get sick. But fasciitis and my mind just went blank. The skin-eating bacteria and stuff, they're actually colonizing the skin and destroying tissue. That's pretty
Like cellulitis.
What's that?
Cellulitis.
Well, cellulitis is one I'm thinking of.
The flesh-eating
MRSA.
bacteria?
Yeah, the flesh-eating bacteria. What's it called?
Staphylococcus aureus.
Like the one overseas?
Yeah, it's not overseas anymore. It's everywhere.
Yeah.
Hang on, I thought I had
Right.
something up for that too.
Necrotizing fasciitis one?
Yeah. I had all this stuff prepared to be organized, and then I changed plans like 3 times. So, I guess we're not doing that. I'll think of it when I stop thinking about it. All right, exotoxins are poisonous proteins shed by bacteria during bacterial growth. Endotoxins, proteins, polysaccharides, and lipids released when bacteria cells are destroyed. Which the destruction or lysis of cells is pretty normal part of their life cycle. So we treat bacteria with antibiotics. They're designed specifically to kill bacteria. A lot of them, most of them, in fact, work by destroying the cell wall of the bacteria, causing them to lyse. And there's a lot of different antibiotics out there. The ones that will affect gram-positive won't always affect gram-negative. That's one of the reasons gram-negative are harder. The good thing is that the ones that will affect gram-negative will also affect gram-positive. That's why usually where the organ system affected will affect what medication you get, because that has to do with, one, the type of bacteria more common there, and two, how that bacteria gets into the body and to that organ system. So for instance, like ANSEF is really good about getting into the skin tissue and into the bone. So if you have an open femur fracture, you're probably going to get ANSEF, whereas Recefrin is a lot better for getting focusing on softer tissue injuries that are closed. So viruses.
I think that's something all the hospitals keep a chart of, is which antibiotic's good for which infection. So
right,
like that.
Right. A good Merck manual is pretty good to have around for the apocalypse. It goes through a lot of that. And for those of you that didn't know, penicillin is in fact the byproduct of a bacteria. Of a yeast. It's a bread yeast, in fact. So you can actually make your own penicillin if you want. I wouldn't recommend it. Not that I've tried. So a virus is basically made of RNA. So the difference between DNA and RNA. DNA is a building block of life. You have the double helix structure. It has a blueprint of all the life in your body, right? When your body needs to access that to make something, like say it needs to make a protein to help you metabolize sugar, it uses messenger RNA, mRNA, basically makes a printout of a certain section of DNA, and then it uses that printout to make another section of RNA, and that second iteration of it folds into whatever it needs to be. It's designed to do that. It folds so it can function to carry that sugar or that protein or unlock that alpha-1 receptor. Okay, viruses are only RNA. And viruses do not do their own metabolism. They're dependent on the host cell for metabolism. And what they do is they trick their way into the cell. They basically attach some of their RNA into the DNA. And so when the cell goes through its normal metabolism of printing out that mRNA, it actually prints out some of the virus's RNA with it and making more of the virus. And that's how all viruses work. It's what they do. To prevent that, there's a lot of things that can be done to prevent the attachment of the bacteria or the virus. There's medicines that will help prevent the printing out of that mRNA from the virus. There are medicines that actually destroy the virus outright. Those are less common because it's hard to isolate just destroying that virus. It messes with the host as well, and that can be bad. Somewhere in the neighborhood of 400 types of viruses. We all have viruses in us. There are some people that believe that viruses have to do with our evolution, that some of those mRNA splices helped us evolve into something different than we used to be, or into the future into something else. I've never seen anything solidifying that as like theoretical fact. It's just more of an idea. But we all do have our mRNA or viral RNA spliced into our DNA. It's kind of the normal way things are. I'd be kind of curious to see what would happen if we can get rid of it all. It'd probably turn into a puddle. So,
I bet they're doing that in China.
where do you think the COVID came from, man? All right, so a prion is kind of interesting, and a prion is basically just a free-floating RNA. There is a lot of evidence that there are prions up in asteroids and extraterrestrial objects, that prions can survive in this vacuum of space, which is interesting because that may be part of the way RNA came to Earth, which a lot of that's some interesting reading. I'm sure you can find a wiki on that. It's important to note that our DNA and our RNA, they want to be in a certain pattern, which is interesting if you really think about it. So when we print out a certain pattern of DNA, it's always going to fold the same way. And if we break it apart, it's going to want to go back together the way it was. It's kind of like a silly putty or some such. It has a memory of the way it's supposed to be. And that's how PCR works, how we can determine what things are. Because we stimulate it to rebuild itself the way it was. So prions, like mad cow disease was a prion. They're really hard to detect. They're really hard to filter out. And that's why if a cow is determined to have it, then basically the whole herd is destroyed because it's too hard to test for. That's gotten better over the last 10 years or so. Other microorganisms are fungi, good old mushrooms. Kelly, are you losing? Do you have any input? So yeast, molds, mushrooms, they're all fungi. Thrush is common. Like people that are on broad spectrum antibiotics for a long time, they end up getting thrush, which is a fungus in the mouth. And it's just because it's an opportunistic. The body's normal flora is gone. The normal flora helps prevent that fungus from taking hold. Once you take that broad spectrum antibiotic, it kills off the normal flora and the fungus can take hold. So protozoa is a little bit different. It's actually a single-celled organism. It's an amoeba. Toxoplasmosis, you've heard of that, in or around Lake Travis, causes the brain-eating amoeba. That's bad. It can be injected through mosquito bites. So malaria is actually a type of single-celled organism. It's not technically a protozoa, but it's the same. And it causes malaria, and that's one of the reasons it's hard to treat. It's super small. And so technically malaria is a parasite, but usually when we're talking about parasites, we're talking about roundworm and the like, which you can run around barefoot, see it on your dog every now and again. Intestinal worms and flatworms and all those worms are gnarly. All right, so we don't just get exposed to a disease or bacteria and all of a sudden we have it. There's a process involved. And we're going to learn things about virulency and all that here coming up. And you have to get exposed to enough of the virus to overwhelm your initial immune response. So if your initial immune response can crush that infection, then you might not get an immunity to it. So one of the things that they run into with viruses or with the vaccines is they have to stimulate enough of a reaction that your body has a memory of it. And that's why the mRNA virus that you hear about for the COVID is interesting, is because it bypasses the initial immune response altogether, and it just goes right to being printed out as mRNA, like I talked about earlier. So it's pretty fancy, pretty cool stuff. It's new. Probably going to lead to zombies or something, but we'll see. So infectious agents and diseases, animals, humans, insects, environment, everything can get sick. A lot of times, the animal or insect being sick is a reservoir. It passes it on. A lot of times they don't get sick themselves. They're carriers, and they pass it on to us. Like mosquitoes don't get sick with malaria. They just pass it on to us and make us sick with malaria. So when a host and infectious agent come together at right time and conditions, disease transmission takes place. All right, so there's conditions that have to be met, and that's why we wear a mask for COVID. I'm going to talk about COVID a lot because it's kind of current events. So one of the reasons we wear a mask is it prevents the spread of some of the disease, so decreasing our viral load so we don't actually get infected with it, and that's important, especially if you're immune compromised. So we can spread disease all manner, airborne, contact, saliva, blood, food, water, and soil are big ones. One of those cool jobs I had back in the day, I worked for the state, and we would get samples of anthrax all the time because certain cow out in West Texas would dig in the dirt, getting their what little grass it can, and they would get anthrax from it because anthrax is dormant in the ground all the time. but that poor cow happened to eat the wrong blade of grass, gets anthrax, and dies a terrible death. Farmers don't know why. They call the vet. The vet takes a sample and sends it to the state, and the state tests it and is like, oh crap, that's anthrax. Pretty common, more than you'd think. Probably about 50 or so a year. So bloodborne diseases transmitted by contact with blood. Bloodborne disease, you guys get that. The big ones there are the AIDS, the hepatitis B, C, D, and syphilis. So you guys watch it.
Back to the anthrax real quick, if you don't mind. I'm just curious. What do they do? Do they have to wipe out a herd? Do they spray the ground once
It's a
they're
bacteria,
positive?
so they can either medicate them, but it's usually isolated to one cow.
So just give them antibiotics and
They can, yeah. Usually it'll kill one or two, and then they'll figure it out.
they're not worried about the rest when that
Not
happens.
usually. It's just now.
Wow.
Anthrax isn't that crazy. The stuff that like they use for CBRNE stuff, the chemical
Yeah.
biological
Right.
attacks, is it's specifically made to be more contagious. So the stuff in the ground isn't as bad.
Okay.
I
Cool.
seem to remember that my dad, whenever they had an anthrax outbreak, that they had to burn the cattle. Does that sound
That
right?
would be about right. If it got bad, if it spread really badly, yeah. That
Yeah,
would be
they would just
something
put them in
like
a pile and burn them.
if you have one that gets it and you're like feed troughing, you know, so the one gets it into the feed and the other one's eating, they might spread it that way. That could be a thing. But usually if they're just feeding off the ground, the one gets it and it's isolated. Now,
Because that's why I was thinking of Army days where I was like, they have to burn everything then. Okay.
yeah, I mean, so if you had an infected cow and it went to the feedlot, yeah, you're probably going to have a problem. The big one they burn, though, is the mad cow disease. Now, I might be wrong. Maybe they do burn anthrax, but
I just remember that my dad talking about, back in the day that they had something happen to their cattle. Maybe it was hoof and mouth. I don't know, but it was brucellosis, and they had to burn them.
there are actually vaccines against anthrax, too. If you got to go overseas with the United States military, you probably got one of them. I'm immune to everything. So some infectious diseases are transmitted through air. Keep in mind that particulates and air transmission are different. So, for instance, COVID is transmitted by particulates, by droplets. It doesn't itself float around in the air. Now, they refine that, and maybe it does, maybe not. They're not sure yet. But some diseases, like, say, tuberculosis, can actually, on its own, float around for a while and spread itself. Most, though, they get stuck in the mucosa, and so when you talk, and that mucosa spreads. And the difference there is that the water, the spittle is actually heavier, so it doesn't float around as much. Theoretically, not as transmittable. So there are a lot of respiratory diseases: RSV, flu, COVID, N1, H1. These are all upper respiratory diseases. They get in the upper mucosa and they propagate. Now that being said, they can spread to other systems, and as that starts to happen, we get this thing called SEERS and sepsis, which we'll learn about here shortly. How am I doing on time? I'm 20 minutes into it. I'm doing pretty good. All right, so there are fecal to oral routes, and it's not as disgusting as you guys are going to think in your heads. It has more to do with contaminated water, especially. The village upstream from you is using the stream to do their business. You're using that water to drink. You end up with cholera, some nasty disease that's fecal oral route. So anytime you have open wounds, especially if you're the one with the open wound and you're working in the field, make sure you put a Band-Aid on the damn thing. We wear gloves, but those gloves break pretty regular. An open wound is a great way to spread a sickness that you normally wouldn't get, or to receive one that you normally wouldn't get. So we work in a closed environment a lot. Once we get them into the ambulance, we're isolated with them. I suspect we'll see face masks being a normal part of EMS care into the future. Probably should have been already.
In the back of the ambulance, I'm a fan of putting everybody on an oxygen mask. Then they won't give me anything.
Fair enough. Fair enough. So I suspect we'll see that where we'll all start wearing masks, and it'll take a big bite out of the flu problem. And we always use protective barriers. That's kind of part of what we do. Cleaning and sanitation of the ambulance is probably something we don't do anywhere near enough, nor do I think we could probably do it enough. Um, Again, COVID, we've come up with some cool systems that make that a lot easier, and maybe that'll be part of a weekly cleaning these days coming in the future.
We actually did a swab on everything in the back of our ambulance one time just to see what would grow, and it was the radio.
Was it? Yeah, I can see that.
Yes, because everybody touches that radio with gloves, without gloves, and the radio. We had one in the back, a handset. That one and the one up front grew the most stuff. Kind of scary.
Yeah. When I took microbiology back in the day, we had to do that, like sample something, and the girl with me sampled her face, and it was the thing that grew the most. This young, attractive girl, but it was probably her makeup, by the way. And makeup is notoriously bacteria ridden. Just so y'all know, little morsels of fact that aren't going to help you do anything in life. Not all infectious agents are going to be communicable, and there's a viral load or a load amount. So there's a certain amount they have to be exposed to for it to take hold. That's obviously going to be different for each person in each situation, but we basically determine that, anthrax, how you have to get exposed to 1,000 cells of anthrax. And one of the things the bad people will do is they'll take that anthrax and they can make it super, super strong, super virulent. And they can make it so that it's finer mist. So when you take one breath, you get that 1,000 and you get sick. And you can also only get sick off 500, right? That's important to know. And again, that's why we wear masks. That's why we wear PPE, because we can get exposed to something and our initial immune system can cover it and get rid of it without us getting sick, without us showing signs of it. But if we get too much of it, then we do get sick. We can die, have long-term effects, go into sepsis, and then that's bad if you didn't know. And that's why we try to minimize the contacts. The CDC is saying something like 15-minute contact without a mask is probably okay and all this stuff. And that's why you see those rules come out, because they're saying that you're unlikely to get enough of the COVID virus or the flu or tuberculosis if you have a certain amount of contact with them. Keep that in mind. It's pretty useful for a lot of different things to not freak you out when you have somebody cough in your face. All right, so to get infected, you have to correct mode of entry, the virulence of the organism. I mentioned that a couple times. Organism strength or ability to overcome body's defenses, the number of the organism transmitted or the dose of it, the host resistance. So you might, I might get exposed to anthrax because I've had that vaccine in the past and not have any problems, whereas one of y'all might if you haven't had that anthrax vaccine. Same with smallpox. I've had that one too. That one's a fun one. I'm pretty much immune to everything except for the flu. I get that every year. So the phases of infection, latent period, communicable period, and then incubation period. So the latent period is once infected with the agent, the host can't transmit the agent to someone else. So you have it, you're sick, and your body is losing the fight against it, but you don't have enough load to transport to anybody else. Communicable period is you may have the disease, you may not. You may not show signs or symptoms yet, but you have enough of it that if you have contact with somebody else, you can spread it. And then the incubation period, time between exposure and presentation. So I get exposed to COVID. I don't have it show signs or symptoms for 5 days. That's the incubation period. Any questions on that? So so an antibody.
I do have a question.
Yeah.
When they're talking about the PCR, that the cycles on it, whenever they're changing them now because they've been running too many cycles and that was showing false positive. Explain that to me.
All right. So I mentioned how the proteins and we'll just go with proteins in the body. They want to be in the form that they're supposed to be in. All right. So if I can take that protein and I can put it in a solution with a bunch more DNA, it's going to want to be in that form. It has a plan already, a blueprint of how it looks. So it takes all those raw materials and it makes more of it, because there's that, you seeded it basically with the way it's supposed to look. And so when they run a cycle, it has 10 minutes to make more of that one protein if it's there, right? And then you run it for 10 more minutes, and it had 20, and then you run it every 10 minutes, you run it, and it has more and more and more time to make more of that seed thing, right? So if you have a little bit of it in there, in 10 minutes you might not make enough to show up on the sensitivity of the test, but if you give it an hour, it does, because you had that one little dose, one little sample of it, but it's not a big enough dose to get somebody sick. But when you amplify it for 40 times, which is what they were doing, you end up with it.
So left alone, it's going to grow more and more and more. But if you just do it on a controlled setting, which is a normal exposure time, then it wouldn't grow.
Right. Well, the PCR, it's kind of like incubating. The EPCR,
I got you.
It's incubating it, so it's making it grow. It's giving it the perfect conditions to grow.
Gotcha.
So it's going to grow faster, and they can figure that out about how long it's going to take. So, like, you might have gotten exposed to COVID, and you might have some of it in your system, not enough to get you sick. Your body's going to handle it. Your initial immune response is going to handle it. But when you do that PCR 40 times, that 40th time, you amplified it enough that it shows up. And now you have a positive when maybe they're not really sick. So viruses and bacteria have surface proteins. Okay, so when we have an antigen, I'm going to use COVID, it comes into the system and the body sees, hey, this doesn't belong here, and it has a couple different ways of absorbing it and getting rid of it. If it gets a contact with enough of it, the different immune cells start to communicate and say, hey, I'm seeing this thing, you're seeing that thing too. Okay, this might be serious. Let's start making a defense against it. So if you get enough of it, your body starts creating a defense, and that defense is called antigen. Well, the antibodies is what the body makes. The antigen is a protein or whatever it is on the outside of that virus or bacteria that the body recognizes as being foreign. It's a friend or foe, blue force tracker. So window phase is the time between exposure to disease and seroconversion, and that just means it goes from you have the disease to now you have either an active immune response against it or not. And the disease period is just how long you're going to be sick. It's the onset of symptoms to resolution. All right, so the immune system is pretty complicated. I try to keep it simple for myself because that's how I remember it. It fights disease by protecting from invaders. It must be able to differentiate self from oneself. So again, friend or foe. And it creates an inflammatory response. It does that by sending resources to the site of infection. And those resources are eukaryotes and a few other ones, neutrophils, macrophages. They all come to the system and they flood that system, and that creates some inflammation. On top of that, a lot of the stuff that goes actually creates the healthy cells around it to inflame, engorge with water, and it's a protective measure, and it creates inflammation. So the body is purposefully creating that inflammation. It generally is a good thing in a small amount. The problem is if that inflammation gets too big or the virus spreads and you get too much of that inflammation in too many body parts, it deregulates the system, so it can't get rid of that inflammation. It just keeps adding more and more inflammation to it. Because the normal way it would work is the body floods it, it inflames, and then other things come in and start clearing that out. Just clearing the inflammation out, clearing out the bad stuff. When you get into SEERS and sepsis, it stops being able to deregulate it. So it just keeps getting inflamed more and more, starts to spread to different organs, different tissues and different organs, and creates a big problem. So
along that note, just because we're talking about COVID, why is it, do you think, that they're having so many profound immune system response on some of these patients and they're dying from anaphylaxis?
COVID is pretty well known. I'm not an authority here, so please don't.
Not from the COVID, but from the actual immunization.
That is a good question. So just based on
we can move on. I just was wondering.
No, we got plenty of time. I'm going too fast. I'm a fast talker. So I am not an expert on this. And please don't go making any Wikipedia entries based on what I'm saying. Um, they selected various proteins that they hoped would mimic the COVID virus, and they pulled a few of the proteins off of it. So some
Hmm.
of those proteins are causing an immune response from people. So one of the big ones that the Moderna one, they used a placental protein, and that's why a lot of doctors are like, wait a minute, if you inject that into childbearing age women, their body's going to create an immune response against
Mm.
that placental protein. And so if they get pregnant and they grow a placenta, the body's going to attack it. And there was that concern, which apparently it is still a concern. And how that's going to pan out, I don't know. So it's a similar thing. Some of the proteins in it might just be, they might have selected poorly. And that's why a lot of people are reacting worse to the Moderna that I've heard. Some people are than the Pfizer and vice versa.
Hmm.
So if we could do a certain testing, we could probably, I just lost internet, I think.
Oh no, you're there.
All right. Uh, and that's why, if we could do like a quick DNA test to determine which vaccine would be better for you, that'd be awesome. But we're not there yet.
Okay, thank you.
Was that a good answer? I don't even know.
Yeah, I didn't know they used the placental protein. That's interesting. So
Yeah.
that makes sense. Yeah.
Yeah.
I think everyone I know got the Pfizer because we all got it early, but
Right.
my mom got the Moderna. So, wow, that's
Well-
good to know. Interesting.
Well, and the Pfizer is the one that was having so many deaths there
Was
for a
it?
while.
Did it really?
See, I've heard more
Yeah.
about bad things from the Moderna. So
Yeah,
Oh, wow.
choose your poison, I suppose.
right.
Yeah, I was disappointed. I got 4 hours of chills and no superpowers. I was really hoping something so new. I was like, this is it. I'm gonna be an X-Man. I'm done.
Yes.
No luck. Just some chills.
As long as they weren't multiplying.
I haven't taken it, and I know I'm that person.
Honestly, I would wait for the Johnson & Johnson because it's not the
Yeah.
mRNA. It's a more of a established technology, if you will, and it's a single shot,
I like that idea.
which is supposed to be approved today or tomorrow. I thought. What's the date today?
Well, and this is off topic a little bit, but my husband he has myeloma, and I'm like, no, you're not taking anything yet until we figure out which one is going to work, because your immune system is shot to begin with, So he's like, well, if I get it, I'm going to get sick, and I'm like, I'll take my chances on that.
Yeah, that's a tough one.
Yeah, it is tough, and we've had lots of conversation. His oncologist gave me the stink eye when I said, no, he's not going to take it. And she's like, why not? She said, well, I took it. And I said, you're not immune suppressed. You don't
Right.
have cancer. Hello?
I think right now the hard
So-
part is finding a place to get it.
Well, the VA, obviously, he's a VA person, but here in Junction, we have an abundance of them. And first responders, because he is one, he was going to be able to get it. But again, I said no.
So we're going to learn here in a little bit about what are we going to learn about? Cell-mediated immunity and humoral immunity. So cell-mediated immunity is a cell kind of does some stuff itself. Phagocytosis is one of those. So when you have the initial bacteria or virus or fungi or whatever, there are cells in the body that just kind of envelop it, take it out of the system altogether, protect the body from it, and destroy it. If there's just a little bit of it, it's not a big deal. The body just gets rid of it and moves on. But if it starts to get too much of a viral load, cells actually communicate. Cell signaling is a thing where they'll communicate that, hey, I'm getting a lot of this one protein, and the other cells are like, hey, me too, and it can start stimulating an actual production of antibodies. Those antibodies don't usually help with the current disease, but they'll help the next time you get it. They will help if you're sick long enough. So cell-mediated immunity generates various T lymphocytes react against specific antigens. Okay, so humoral immunity systems properties of memory and specificity. So T lymphocytes can be very broad spectrum. You dump a bunch of T lymphocytes out and they just start killing stuff. They start killing, if it's not listed as friend, it gets knocked off. Humoral immunity is you get more specifically to the flu or specifically to COVID or specifically to RSV or whatever it is. And those are antibodies, immunoglobulins. They protect against most infection agents to which body repeatedly exposed. So, and that's why we get flu shots and immunizations. So there are the 5 classes of antibodies. Some of them are more specific than others. And again, the immune system, we simplify it so we can remember it and understand it. It is actually very, very complex. People get MDs and PhDs in that crap to be able to do research on one small aspect of it. So IgG, IgM, IgA, they all have different functions, different specificities. Some of them are broad spectrum. Some of them are focused on specific things. Some of the IgD helps the body identify what's friend or foe, so it knows which ones to attack. It goes out and attaches to the bad things. And then IgE helps the mast cells find the IgD that's attached to other things, right? Pretty complex system. And when we give ourselves immunizations, basically we're giving ourselves proteins from a bacteria or virus so their body can create antibodies against it. So the complement system, so once our immune system is set up and going, it has multiple ways of attacking it. It can do a direct attack, it can do indirect attack, it can increase your body temperature so that the bacteria can't propagate, things like that. That's where the fever comes from. And that's why we generally want people to have a fever until they get up to 103, 104. Then we want to start controlling that because that can lead to more systemic problems than just the bacteria can do. They say there's 20 proteins at least that work with antibody formation and inflammatory reaction to combat infection. So any given time you get an infection, 20 proteins are going to it to start making an effect. Okay, so the lymphatic system is something that medics don't learn about anywhere near enough. I wish we did. It's kind of interesting. But it's basically the drainage system. It's the sewer of the body. It's the way that your body gets rid of all of the waste product.
It's only whenever they've had a mastectomy, right? We worry about it when it's IVs, and even then, in emergency situations, you're going to do it anyways.
Correct. Right. So it's not something medics usually pay a lot of attention to in class. So secondary circulation systems, the spleen, the thalamus, the lymph nodes, and lymphatic ducts. It's a system designed to transport all of the waste product and break it down so it can be exposed of, or peed or pooped out. Interesting enough, and I didn't know this, it's the same lymph, or the fluid lymph is the same composition as normal intestinal fluid, and that just shows you that it's designed to break things that are hard to break down. So disease prevention, if your lymphatic system isn't working, and this is I know people that have had cancer, and one of the things that happens when you have cancer is they take lymph out, because if it gets into your lymph node, it can spread easily. So they'll take the lymphs in the area out and test them to see if it got in there. And once you take those lymph nodes out, that changes the drainage system. You're basically blocking part of the drainage system. And Crystal has a big machine that's used to kind of leg squisher, we call it. It squishes all of the interstitial fluid all the way up to get it to a part of the body where the lymph can still function, because they had to take most of the lymph out of her lower extremities. And it allows that fluid to come up and be disposed of. Because if it's just stuck in the legs, there's no way to pee it out of your toe. Not yet, anyways. I'm sure we can make that up here in a few years. So it's kind of interesting, and it's a profound difference, like 2 pounds of weight loss sometimes. It's crazy.
Want to see, and the right side drains into one section of the heart, and the left side in the body drains into the other section.
Right.
I can't remember.
No,
it's been too long ago that I looked at all that.
I kind of looked it up to try to go into some of that, and it just was over. My brain didn't pick it up.
Yeah.
So the spleen is pretty big on it. It helps generate the antibodies, and it helps filter out some unwanted particulate matter. I'm going to start going through some of this. I want to get to the sepsis stuff So kids, babies, brand new newborns, they get all of their immunity, passive immunity, from the mom. So once that connection is severed, the kid doesn't have a great immune system, and that's why we're very cautious with newborns. You don't want the entire world to come and see that kid the first few days. They continue to get immune boosters from the mom's breast milk, and that's why it's important for the kids to breastfeed. It's better than just the formula. It actually provides some immunity. So passive immunity, it just kind of there. It helps. Active immunity develops antibodies in response to inoculation by killed or modified form. So there used to be a time when they gave live virus immunizations, where they took a virus, they heated it to a certain point where they determined it was dead. They gave you a shot of that so your immune system could react and give you an immunity. The problem is that some of those viruses didn't all die, and people would actually get the disease. And doctors and nurses are still dealing with that fallout today because people now think that you can get a vaccine and get sick. It doesn't work that way, especially with an mRNA one. You might get the symptoms, like the flu shot. You don't get the flu, but you might get the symptoms of the flu from it. So just keep that in mind and say that a lot.
Yeah, TK, I think you can skip through this and everybody can
Yeah.
do this piece on their own and go straight to sepsis because that's the meat and taters of it, I suppose.
I was afraid I was going to get through the infectious disease stuff in 20 minutes.
No, that stuff is hard. Man, you're doing a great job. I don't think I ever learned about IgG, IgM. I just kind of memorized it and went on.
All right, so we got about 15 minutes. See if I can speed around it. That's not true. We'll go longer if we have to. Sepsis is the end game. Systemic inflammatory response syndrome, or SIRS, is the process of getting to sepsis. So you end up sick, so you have a Foley catheter in place, draining your bladder, that stays there a little bit longer than maybe it should, or whoever put it in didn't handle it in an aseptic technique. You end up getting a bladder infection. That bladder infection spreads into your kidneys. From your kidneys, it spreads systemically, and you start getting SIRS, so systemic inflammatory response. So what's going on there is that this infection is getting everywhere, and therefore everywhere is getting an immune response, and therefore everywhere is getting inflamed. That can be really bad. You've all stubbed your thumb, and you know how bad it is. Or you got an infection from your thumb, and then your hand gets bad in your arm, and you get maybe a cellulitis all the way up your arm, and it's pretty difficult to deal with. Now imagine that happening on your liver, your intestines, your spleen and pancreas and stomach, and how that's going to happen, how that's going to work, and the effect it's going to have. So sepsis is the next stage. It's the most common cause of death in debilitated patients in hospital intensive care units. So think about that. So it can start anywhere. It can start with stuffed up nose, but you're immune compromised and you don't want to go to the doctor, so you stay home. Next thing you know, it's down in your upper respiratory or lower respiratory tract. It gets in your lungs. From there, it just spreads and it propagates. Sepsis can result from medical intervention devices. Anytime they have a freaking catheter in, if they're acting lethargic, they probably are septic or preseptic. Please just do a temperature. And then again, signs of infection, elevated temperature, elevated heart rate, decreased blood pressure, that is a sepsis alert. You need to call a hospital and tell them. Start dumping fluids into them and start your Levophed. Not that we have that at our department, but we cover that here in the end. A lot of people, your standard people that you would think, immunocompromised, hospitalized, pre-existing infections, severe trauma is at risk. Severe trauma they're going to get two different broad-spectrum antibiotics, Rocephin and Ancef. They're going to get those right off the bat. Some EMS services in the area give that in the field, the Ancef in the field for any open injury. Pretty cool stuff. It makes a huge difference in that long-term correction or prevention of sepsis. And the very old and very young, again, are more susceptible to it, and that's because they're not as capable of complaining, basically, and presenting their symptoms. All right, symptoms: heart rate over 90, abnormal body temperature, and again, there are some infections that will drop your temperature initially. Almost always, though, it rebounds up into an actual fever. So if they're cold and they're shivering and they're saying, I just can't get warm, and you take their temperature and it's 95, it might actually be that low. What would be that low? 96, 95.5. It might actually be that low because the body's response has been perverted from that illness. Usually staffs do that weirdly. Tachypnea, which I guess that's really a heart rate over 90, so we got that in there twice. It's important, apparently.
No,
Abnormal white blood cell.
tachypnea,
What's
breathing.
Oh, tachypnea.
That's
It is, isn't
breathing.
it? Yeah, I can read. That's why I'm teaching you. Can't teach, right? All right, so abnormal white blood count, that's not something we're going to do in the field, but again, it's becoming more common that some ambulance services are actually doing CBCs in the field. They're doing full chemistries. That would be cool for us to go to, but first we got to get some new ambulances. I should not have said that on a recorded line. It's done. And
You can edit that out, right?
Yeah, I hope so. So severe sepsis, you're going to see a drop in blood pressure, and that's evidence of hypoperfusion. By the time their blood pressure starts dropping, you're behind the 8 ball. As soon as you suspect it, start doing fluids.
You know, at the conference, they were recommending how much fluid, and it was an astronomical amount of fluids that they're saying push. Now, I can't remember the number. It was like, oh, God, y'all remember what it is?
3 liters would be standard.
What?
Yeah.
Yeah, when I did it in the hospital, I believe most people, average people, got 3 to 4 liters, and then you'd get your Levaquin, your Rocephin, and that was just because they had to start those, get them done before the vancomycin would come down from the pharmacy, because they quit letting the nurses mix their own. The pharmacy had to do all the vancs. So, but yeah, dual IVs, start flooding them with fluid, no joke.
And it's like 3 liters in an hour. It's not even like
yeah, it's fast.
Day. It's before they leave the.
Yeah, that's just what they get down there before they go upstairs. Yeah.
And I think we tend to be really overly cautious about that. You know, you think about an old person that has an indwelling Foley, and we're always taught, oh, don't give them too many fluids because you're going to send them into CHF. And I think we tend to be too cautious about that. When it comes to sepsis, I think that that's a conundrum that we get into about, oh well, if I flood them too much, and because we've been taught hold back.
Yeah, the CHF fluid crept over into the renal failure, which crept over into the sepsis.
Right. Right. And
So,
the solution to that is listen to your lung sounds early and listen to them as you go. I actually had that guy on the ground dumping fluids and just couldn't get his pressures up, dumping fluids. And I started kind of going easy while I'm getting the Levofed. That was a mistake. Just keep dumping them. Just keep going. 3 liters in an hour would be a starting point.
I'm the same way. I didn't get comfortable until I did it in the hospital, and you're like, oh, they don't die. Okay.
Right.
So same thing.
Right. Good information.
So keep in mind for septic shock, you want to focus on their mean arterial pressure, which the monitor does it for you. But if you're actually a good medic, it's your diastolic plus systolic. So 2D plus S divided by 3. That gives you the mean arterial pressure. That needs to be above 60. That's your target. If it starts going below 60, you're in dire straits.
Say that formula one more time.
It's D squared. Well, I can say it 3 different.
There's a couple different formulas: twice the diastolic plus the systolic divided by 3, or the formulas that figure it out.
Systolic divided by 3.
Gotcha.
The folks we have, the advanced students, I tell them to like 60 to 90 is the range we want for their map.
Right.
Does that sound? Yeah.
Oh, I'm not doing. Yeah. All right. So early goal detected therapy, supplemental oxygen, don't forget that with these patients. So when they get to the hospital, they're going to central venous line placement, fluid resuscitation. You got to keep the blood pressure high. This isn't one of those people that you need to do permissive hypertension. That's a trauma thing, so you don't want those to bleed over into each other. You can get their blood pressure up to normal ranges. That's not going to be a problem. It's not going to stay there. And broad spectrum antibiotics, Foster, go through those again. What were they that you guys used?
So they usually get Levaquin. It depends on the doc, right?
Right.
But it was always Levaquin and Rocephin to get them started, because the Levaquin runs over a half hour. I think the Rocephin runs over an hour, and that buys enough time for the vancomycin and usually another one, to get down and start running it before they go upstairs for 48 hours of constant vanc to keep those.
That's a pretty large amount of synthetic antibiotics right there. So.
Hey, TK, can you? There was a question on the test that I put out there, and it had to do with the. I just went blank on the CO2, and I can't remember the test question. Do you guys remember it since y'all took the test? It was about this if the level was at 45 or 50 or 25. I can't remember what it was. Let me go into the other screen.
I have my test here real quick. I'll look it up.
Yeah, look. Yeah, it had to do with the CO2 level.
Right. So while he's looking it up, I'm going to start talking about that. So acidosis is the sick patient's enemy. Acidosis is going to kill him. It's going to lead to in trauma, your clotting problems and oxygen carrying problems, and in a septic patient, it's going to do the same thing. That acidosis is going to lead to another thing that's going to lower their blood pressure. And once you start getting acidotic, you're going to have a hard time treating that. Your CO2 is going to help you determine that in the field, because we're not going to be able to do chemistries or blood gases to see what their pH is. So we can use a CO2 reading to determine that they're acidotic or not, and start adjusting their breathing pattern for that.
There's one where it says the patient with an indwelling cath that has a CO2 of 28. Is that the one you're thinking of? Yeah. Respiratory rate 22, CO2 of 28, tempo 101.2, pulse 110.
Right. So.
And then, I think the answer is D, sepsis.
Right. So in this patient, yes. they're.
That's what I put.
Hey, me too.
So in this question,
well, somebody else was telling me that they chose a UTI answer, and I'm like, well, yeah, they've got a UTI, but that's not the problem.
Renal failure, rhabdo, UTI, or sepsis are your choices.
Yeah. So the CO2 being under 35 to 45 being normal, under 35 implies acidosis. So that means we need to start treating that. So what if we have to tube this patient? Okay, so we intubate him, and we're going to breathe for him normally, like we would at 10 to 12 with high flow oxygen. We're going to keep their sats up. What's that going to do to their EtCO2? It's going to continue to drop because they're breathing at 22 minutes to get rid of that CO2. They're compensating for that acidosis. And if we tube them and we change their breathing rate, then we're going to cause serious problems and kill them, like quite literally. And that's a big important thing to keep in mind. If you do tube somebody and we use a CO2 to guide or resuscitation, if their CO2 keeps dropping, breathe faster. So you can see up on the screen, hopefully, anyways, the sepsis protocol for ESD1, which we need to go through and change our little patch up there since we got the cool new red one. And you can see here, temp over 104, orbital low 96.8, heart rate over 90, respirations are fast, altered mental status from baseline, and then systolic blood pressure less than 90. So the only one I haven't mentioned repeatedly is the altered mental status. If you have any of these in altered mental status, be cautious, especially if you have a presumed source of infection. That's going to lead you down the sepsis. Establish IVs times 2, 30 milligrams per kilogram. So if for me at 100 kilograms, give or take, that's 3 liters. And you can just put them under a pressure bag and let them go. If you have a dialysis patient, everything's different. Their electrolytes are always out of whack. A lot of interesting stories coming out of the whole snowpocalypse, and people not being able to get dialysis because there was no power. A lot of ambulance work around here in Marble Falls for that.
Here too, because we had several that couldn't go. Yeah. So yeah.
I mean, what do you do? Yeah. Just sit there and die? They have some medications that they can give them that helps with that, helps pull out some of the potassiums and stuff. And apparently they were doing that, but EMS was having to distribute some of that even. Some interesting stuff.
Yeah, way back when I had a guy whose shunt came out. I had to tourniquet him and take him to Highland Lakes, and Dr. Smith got him to open up the dialysis clinic. I don't know how. In the middle of the night, we took him back there and they put a new one in, but it was like they had power. It's not the same as what we ran into here. Right. So yeah, they got to figure that out.
So with a dialysis patient, you want to be more cautious with the fluid you give them. 250 boluses up to 15 milliliters per kilogram, and you want to keep a closer eye on that blood pressure. Anybody that you suspect is in sepsis, do your BPs Q2, Q5 minutes at worst. Get it trending on it. As soon as you start seeing that trend of it getting bad, start intervening. For ESD1, we do push dose pressors, so 0.5 to 2 milliliters. every 2 to 5 minutes. I really wish you would let us do drips, but we don't. If you don't know how to mix your push dose, we have the triple valves. You take your 1 to 100 or 1 to 10,000. You take 1 cc of that with 9 cc's of saline, and that sorts you out for your dose. And then you give 0.5 to 2 mils of that. Rapidly transport, give you an early radio report that you have a sepsis alert. Okay, anytime we're doing any kind of alert, this is the ESD1 EMS lieutenant speaking now. Anytime we have an alert, we do that early from scene through dispatch. We tell them, I have a sepsis alert, or I have a stroke or STEMI alert while you're on scene, and they're going to tell you where the closest hospital is, and they're going to notify that hospital that you're coming. Once you do that alert, it initiates this broad spectrum of things, getting STEMI teams and stroke teams and antibiotics ordered and ready for you when you get there. And the hospital starts tracking that time. So that needs to be documented in your chart. You need to document that you are calling a sepsis alert specifically for these people.
Do we have specific hospitals to avoid?
No, we don't. We don't do that. We can
Technically, no.
Technically, no. We can go to Cedar Park with this. St. David's Leander should be opening soon. But it'll save us.
Oh, I did think of a cold weather story when you're done. I forgot about it, but.
Oh, yeah? Finally.
Good.
Yeah, I get to join the group. I forgot.
We'll go for it.
Oh, so way back when, I think 2007, this will be short. I think there was a bad ice storm, lasted 4 days. It was like my second year at Austin. 4-day ice storm. I think we were day 2 or 3. So 2 a.m., call for unresponsive under a bridge. We're like, can be a homeless person. We got it. We get there, flashlights. He's not moving. This is going to be a pronouncement. So I walk up, go to grab them. They're bundled up. You can just see their eyes. And as I touch their arm and it's not moving because they're frozen, these eyes pop open like a movie. And my partner said my scream was a combination of teenage girl, horror movie, and grown man who had been totally surprised. So very much alive. Take her to Seton because that's the closest hospital because it was an ice storm. But interestingly enough, she was talking. I spent most of the trip getting vitals and getting her clothes pried off because they were frozen. Core temp of like 93, and the doc at Seton was like, I don't even know how she's talking. And I was like, I'm still absorbing meeting her, so that's all you, doc. Like, I'm freaking out. So yeah, that's again how you can be surprised by the cold because I was like, you should be dead. Very much not.
Wow. Wow.
All right. So anybody have any questions? Anything you'd like me to lie about?
No, it was good. And again, TK, because you have your background in biology, this is really good. There's so much information that I don't think I ever got. Of course, y'all do realize, that was, 100 years ago.
You just don't remember.
We didn't even
got it.
Yeah, we did. Well, we didn't have bacteria when I started,
Still had prions.
Yeah, we hadn't evolved quite like that. So good information.
All right. So you doing the DK, or you want me to do it?
Go ahead. You're killing it.
All right. I'm gonna
take a potty break.
End this. Take a 10-minute break and come on back.
Okay.
Sounds good.